a minute. And first of all, let me say I recommend that you absolutely use rates because it helps you compare areas. It helps you compare tracts. It helps you compare counties because they have adjusted for the underlying population. Now, an age-adjusted mortality rate, if available, is even better because what it does is it takes away the effect of age on mortality. For example, you're going to find higher mortality rates in areas where there's an older population. But an age-adjusted mortality rate takes away that bias associated with mortality, and so again makes it even more comparable. A morbidity rate, any departure, subjective or objective, from a state of physiological or psychological well-being. The biggest problem with morbidity data is that they usually measure it with hospital discharge data or emergency room visits, as you can see on the left. The issue with that is while it gives you an idea of how many sick people are in a community, it's just an indicator. It's not a complete data set. So it doesn't mean that just because people don't go to the hospital, they're not sick. So, you have to understand those types of biases that are built into hospital discharge data. And the challenge I had was that Georgia DPH was not willing to give me morbidity data because it was sensitive, and they said I needed the permission of the Georgia Hospital Association for them to part with that data because it was at a census tract level. So you'll run into barriers, access barriers like this if you request morbidity data. Now, I know that it takes a lot for somebody to go from being sick to dying, but in one way there's a certain objectivity with mortality data because it's a complete data set. Everybody who dies, their death is recorded. So it's not an estimate. It's not a sample. It's 100%, representative of the population. So it's a more robust measure of sickness in your community. So so something that should really consider in terms of what your needs are and objectives are for your project. So with that said, let me move on to the next slide. Anna, you're going to have to forward that for me because I can't do it. There you go. So here's the neat thing, right? So I was very excited when I was looking for data, and I looked at the OASIS system, and I was like, oh my God, they have census tract level data. This is really exciting. But if you look at the left side on the menu, of all the menus that you have, notice that the measure is number of deaths, right? And it's at the census tract level. So the problem with that is you're going to see darker areas, say in the metropolitan Atlanta area, and then you have, so what it's doing is it's basically saying, yes, there are a large number of deaths here, but that could also very well be because there's just a lot of people living there, right? So it's not necessarily because there's more illness. So it can lead to incorrect conclusions, right? So you may think a place is sicker than it should be, but the fact is you just have more deaths because there's more people living there. It's not normalized, not standardized, right? So this is count data, and I would caution you about using count data towards your analysis. Also notice that with the time, you have 5-year aggregate counts, right? It's not annual. And like I mentioned, that there are some mathematical properties of the data and the estimates that become unstable when you look at such a small scale. So always look at the tract level. You should look for 5-year or 10-year aggregate counts. Don't look for annual estimates because they're not stable. Particularly for urban planning projects, we're looking at cross-sectional data or one point in time, and that can be dangerous. You can make a lot of erroneous assumptions based on 1 year of data. Let me move on to the next slide where I show you examples of the difference between county and tract. Okay, so this is an example of county level data. Now you notice the menu on the left, the measure says age-adjusted death rate. right? So automatically now this is a more robust measure because it has taken into account population distributions underlying the death trends, right? And now with the time you have annual estimates. So at the county level, you have enough of a stable population that allows you to look at annual estimates. So these are like really fine details that unless you've been trained as a public health professional, as an epidemiologist, you really don't understand. And this is where a public health department or a public health professional will be really useful to really help you understand what you're getting into with the data and what you can, what you can't deduce from that. Next slide, Anna. So here I have a side-by-side comparison of age-adjusted death rates and then death mortality counts. And you can easily see the difference, right? The map on the right looks like Fulton County with the dark red, which is the heart of Metro Atlanta. It has the highest number of deaths. It's also because it has the highest population. But then you look on the left, which is the death rate. So it's usually calculated per 100,000 population, right? And then you automatically see that it has one of the lowest death rates, which could be associated with the fact that you have more better healthcare access in urban areas. And then the whole picture changes. So I just wanted to introduce this slide and understanding the difference between using death rates and death counts. And it's a very important distinction between the types of indicators that you might use. Next slide. So I just wanted to kind of dive a little bit into my dissertation research and show you some of the diverse data sets that I used for my research. The area that I investigated and the objective of my research was to develop a framework for regional land use planning and how to incorporate health into that. I won't get into the details of my statistical modeling, but I will just show you how I use the data, basically, and how y'all can think about using readily available data. So the study area was the 21-county Atlanta region as defined by the Atlanta Regional Commission, which is the MPO for the Atlanta area. And so the red boundary, that's pretty much what I was looking at. Next slide. So the first step in even starting this research was to figure out what are the main health issues plaguing the Atlanta region, right? How do you set priorities? So you have a project and you know that this is an unhealthy community as evidenced by higher mortality rates, higher hospital visits, and you're asking yourself, how do I set priorities? What can I realistically do? So Georgia Department of Public Health provided me with mortality data for 951 census tracts between the years 2002 and 2011, so basically 10-year aggregate counts. And the reason that this even happens is because many times when you look at a census tract and you look at 5-year counts, you might have a 0 in there. And they don't feel comfortable in releasing data when you have zeros or very small values, and then you don't want to run into the issue of suppressed data, right? So they keep adding up till they have some number to give you on the tract, and this is all HIPAA related, IRB related, so these are, they have to take these precautions because they are liable for releasing that data and violating privacy issues. So that's something that you have to keep in mind. So it's not like they are deliberately making this difficult. They're legally bound in terms of what they can and cannot share. Because anything that can even identify anybody in the remote sense, they will stay away from that. They're very particular. Mortality data is a little bit less subject because I didn't even need IRB clearance to get mortality data because they're not considered human subjects since these people have passed on already. You will run into a lot of issues getting morbidity data because it could be individually identifiable. at small scales. So using Excel, simple spreadsheets, pivot tables, I was able to look at excuse me, how much each disease type contributed to the overall mortality in the region, and also what were the disease types that I could probably address or had some kind of mechanism related to the environment and land use. So I can't address everything. So I looked at the ones that contributed to the highest mortality in the region, namely heart disease, diabetes, lung cancer, and COPD. And that's how I made my selection in terms of which disease types I was even going to look at. And if you could proceed to the next slide. Oh.
Yeah, that's one of the images that didn't come through. Maybe you can just talk about it.
Let me see. Let me
Or
see what I
skip
had
forward.
on that slide. Oh, the next slide I actually had, so I had to take the, okay, I'm not talking about this slide just yet. I'm talking about the slide before. I had to take those counts. Remember, they gave me 10-year counts. So I had to calculate the age-adjusted mortality rates for each of the disease types that I had used for my analysis. And I actually had maps of the census tract level age-adjusted mortality rates mapped by deciles. So I just wanted to show you some patterns, some spatial patterns of disease in the area. So this is, again, a very powerful visualization technique. We all are familiar with mapping, ArcGIS. We use it all the time. So again, a very powerful visualization tool to identify hotspots, areas that we want to focus on more closely. So again, something that as planners we are fairly familiar with doing. And if you want to proceed to slide 14. There we go. The other set of data that I used was land use data that is published by the Atlanta Regional Commission, and this is a really neat data set. Now, I'm only showing you 2 counties, but this was available for the entire 21-county region, 25 classes of land use, and it's really a hybrid data set that addresses both land use and land cover, and it's interpreted from satellite imagery and ownership data from local governments. So it's a very useful tool because it standardizes land use classes across 21 counties. That's pretty powerful. So what I also want to show you here, and this might get a little bit involved, but please stay with me. We often look at sprawl in the urban planning literature to measure health and health outcomes, and there's a common understanding in the planning literature that sprawl is bad for health. But what I really set out to prove in my dissertation is that there's other ways of measuring land use patterns that might better capture certain health outcomes that sprawl doesn't really capture. Because if you look at the table on the bottom between Gwinnett and Clayton, you'll see that the sprawl index is very similar, but really their health outcomes are very different, right? So this got me curious, and I really used another system that landscape ecologists use to measure land use pattern, which is more spatially explicit. I won't get into the details of that, but I hope to publish this, and you know, I'll keep you informed when I'm successful at that, which will have the details of the methodology and everything. But there's a lot of variation in the spatial patterning, which is not captured in the index, in the sprawl index. And this is really what I was hoping to set out to do. But for y'all, this is a demonstration of yet another type of data set that you can find, and in the local area or through your MPO. You can even look for parcel level land use data that you can use, and then you can use these data sets to look at access to jobs, where's the commercial activity, where are the parks. So things like that, to assess things like that in your local community. So these are useful for that. Anna, we can move on to the next slide. The other important thing, and we all know that socioeconomics is absolutely key to health, right? But here's, now in the absence of individual level socioeconomic data, you look at area level measures that give you an idea of the average socioeconomic condition in a tract or county or whatever scale you're looking at. And that really is called neighborhood deprivation. The area level socioeconomic indicator is called neighborhood deprivation. And I calculated this neighborhood deprivation index using principal components analysis with readily available data from the American, from the census, right? So, and American Community Survey data. So again, readily available, not hard to do. You might need help depending on the methods you use. You might need an input from a statistician or somebody who's really very savvy with statistics and data analysis. But in terms of techniques, it's really not that complicated. But it gives you an idea of the average socioeconomic conditions, and these patterns mirror what we already know about the Atlanta area very well. So we were able to validate this deprivation index. There's a ton of literature out there in the social epidemiology literature. There's just tons of methods and tons of papers out there. So, and I have some references on the next slide. But it's also important to remember that area level deprivation acts independent of individual level socioeconomics, right? So the trajectory or the health outcomes of a high SES individual living in a low SES neighborhood is very different from a high SES person living in a high SES neighborhood. So there's an independent mechanism that's operating. And really the best theory to explain this is that the collective resources model, which says that deprived areas are just deprived of resources. So you have, it's harder to engage in physical activity. It's harder to engage in other healthy behaviors like food access and other things. So it's really about collective resources and what you can and cannot have in a deprived neighborhood. And the next slide. So here I have some resources and some very useful literature and sources to look at different ways of calculating deprivation indices. And the Townsend Deprivation Index, Carstairs Deprivation Index, the indices of deprivation were all developed in the UK to begin with. And they really look at the different domains of income, employment, health and disability, education, skills, barriers, and so I have some resources for you that could help you develop your own in your community. Next slide, Anna. You can move to the next slide.
Maybe Erin can move to the next slide, please.
Is that where you want to be?
So, yeah. So I guess that's my last slide. Or I think we can't see the images on the previous slide again. But I'll just conclude and remember that the framework that I used in my research was all about associations, and it does not prove causation in any way. It's a more of it's a way of looking at signals, things that you can track over time to really see how changes in land use, because I did find that certain land uses were associated with certain types of deprivation in levels, right? So they clustered together in certain ways. So it's interesting to see how urban patterns reflect socioeconomic patterns. And so it's something to keep track of over time and see how health status changes as a result of that. And that's very commonly done in the infectious disease literature, particularly for zoonotic vector diseases. like Lyme disease and malaria, and so environmental factors are very important. So I provide a demonstration of how these frameworks can be applied to chronic disease. With that, so that provided really a very high-level overview of how you can use regional data that's readily available. But then I'll hand it over to Aaron, who's going to talk about a more local level, very specific example, which I really enjoyed talking to him about. And I think it really gives you an understanding of how primary data needs to be collected in the absence of any. So Aaron, with that, I'll hand over to you.
Hi, everyone. Yes, thank you, Arthi, and we'll hear from Aaron. I'll just give a quick introduction to Aaron, who has a diverse background in city planning and public policy and holds a Master of Community and Regional Planning from Boise State University and an undergraduate degree in political economy from the College of Idaho. Aaron has worked on a wide variety of planning and policy-related projects, including a national study of creative placemaking through temporary developments, which I think is so interesting, a Treasure Valley Arts and Economic Development Study, community food evaluations, housing and neighborhood outreach and planning. Aaron.
Thanks, Anna. So for the sake of time, I'll try to keep this short, but my name is Aaron Mondada, and I work with a consulting firm called Agnew-Beck Consulting, and we were the primary consultants on the Plan4Health Vista project, which was one of the cohort projects for the Idaho or the National Plan4Health project, which I'm sure some of you are familiar with, and if not, I'd highly recommend looking into it. It's a fantastic project supported by the APA and the APHA, and I think we've had some great health outcomes come from that process. So I'll just give you a little bit of an overview of our project. When we heard there was grant funding for whether it be physical activity or food assessment of a particular neighborhood or a geographic area, Agnew-Beck, along with the city of Boise and the Idaho chapter of the APA and the APHA, came together and identified the Vista neighborhood as an at-risk neighborhood that we felt could really benefit from some food interventions and really trying to improve the healthy food environment within that community. So just a brief overview of the Vista neighborhood. It's a relatively small geographic area that doesn't perfectly cover 2 census tracts, and it has roughly 10,000 individuals and 4,400 households. And what makes this a very unique neighborhood is, I'll talk about the demographics in just a second, but if you look at that map there on the slide, it serves as a gateway between the airport, which you see in the left-hand corner of that image, and then the downtown core of the city of Boise. So it's very well utilized, but there's a lot of disparity that made it a prime target for this particular project. So a little bit as to why we selected the Vista neighborhood, and these are just a couple examples, but across the board, Vista had characteristics that were potentially showed the neighborhood was at risk for food insecurity, or at least the possibility of some individuals not having access to healthy, affordable foods. The median household income was significantly lower than the city's median household income. We see a high rate of renter-occupied housing in an aging housing stock that's pretty much significantly lower than the rest of the community. And perhaps one of the most important reasons why we selected this community was we looked at the rate of participation in free lunch programs with the 2 elementary schools in the neighborhood, and in both cases, those numbers were very high, almost 70% and 85% respectively. So there's obviously some families struggling to make ends meet in terms of the ability to provide food to their families, just in terms of the utilization of the currently available programs. So that led us to select the Vista neighborhood as our project. And we quickly realized that we weren't going to be able to go into this neighborhood and just take a look at currently available data and make recommendations for interventions to improve healthy food consumption within the neighborhood. Some of the challenges we encountered were the area was very small geographically, and so we had to be very careful as to what we were recommending. It had to be context-specific. And in order to do that, we had to have a good idea of what the health environment really looked like within that community. And we realized that public health data just wasn't available. We had no idea diagnosis rates of chronic diseases. We didn't know what kind of food people were eating. We didn't know where individuals were shopping, et cetera. So we really wanted to identify neighborhood-specific strategies for data collection before we made any recommendations. And the focus of our project shifted from more of a food improvements plan to a food assessment. We really wanted to understand what was going on in the community, and we felt that was a very important step. And so some of our final deliverables ended up being a model for data collection at the local level that we're hoping to see implemented in neighborhoods across the city of Boise and anywhere else individuals are interested in this process. So we had to address the fact that there was no real model to follow for neighborhood food assessments. The USDA has done some great work on sort of community-wide assessments, but it really fails at providing the data necessary to look at such a small population. And then two other small things to mention about the Vista Neighborhood was there's a larger initiative with the city of Boise called Energize Our Neighborhoods that was looking at increasing participation in community events and physical health. And so we were able to partner with them throughout this project. But that also meant that the community had been studied pretty heavily over the past few years, and so we had to find a way to collect data that wasn't going to be off-putting to individuals who were already fatigued from over-surveying. So those were our challenges, and I think we had a really great rate of success in terms of working with the opportunities we had available to us. We were able to form a partnership with Boise State University, and this will be integral when we talk about collecting data through the survey we designed and implemented. But we worked with the nursing program at Boise State University and had the students go out into the field and help us gather the data that we wouldn't have otherwise been able to get on such a short time frame. We were able to work with the current neighborhood programs, including the Health and Community Services Board, which was part of that larger Energize Your Neighborhoods community initiative. We were able to work with a local garden school, and one of our final outcomes was really cool. We were able to fund an expansion of the community garden within the neighborhood after we assessed that that would probably be very impactful for a number of families. And we were able to work on what United Way had already done in that community in terms of assessing health. And we were also fortunate to have Dan Kushlin from the Urban Land Institute on our coalition as well. And they were simultaneously doing a study of the Vista corridor, looking at ways to improve transportation and walkability within the neighborhood. So really, there's a lot of culmination of projects going on within that neighborhood, and it was really great to be a part of that. And I think that's contributed to a lot of our success. But what we're really here to talk about is that local level data collection and how are we able to answer the question of how do we assess the neighborhood's demographics and the current conditions with such a short period of time and no secondary data to use. So we had to use a multi-pronged outreach approach in creating our own primary source data, and I'm sure this is not necessarily the most accurate way to assess a community, but given the resources and the time frame we had available, this was the best data we could collect. And so we designed and implemented a 33-question online and in-person survey tool that was distributed to the neighborhood via a postcard mailer, and the students from our Boise State partnership, which I mentioned earlier, went door to door throughout the neighborhood talking to individuals about the survey and about their healthy eating habits. And that gave us some really great data to work with and helped us identify some core trends, which showed us what recommendations we needed to make at the end of this project. Coupled along with that survey tool, we produced key informant interviews. We utilized a grocery store food and cost analysis that took a look at all the local grocery stores, and we did a price comparison and an availability comparison to see if the local grocery store was overpriced or maybe not affordable for most of the community living in Vista. We were also able to do a spatial proximity analysis of the restaurants, fast food stores, convenience stores, and grocery stores to make sure that there weren't any transportation barriers that were causing significant barriers to individuals accessing and purchasing healthy, affordable foods. And we were also able to do a really cool GIS garden inventory that may or may not have been perfectly accurate, but it gave us a good idea of sort of what kind of local food production was going on within the neighborhood. And so that larger package was what led us to our eventual success in determining recommendations and implementation strategies for the neighborhood. And I'll kind of just zip through this real fast. And it looks like some of our images got shifted a little bit in the conversion process here, but one of the questions we asked in the survey was, how many times did you run out of money to buy food in the last 3 months? And we found out that there was a pretty significant population within the community that was having difficulty purchasing enough healthy food for themselves and their families, and so we were able to design some recommendations to specifically address that. And you see the 5 focus areas of our survey on the left-hand side there. And I'll kind of zip through this since we're running out of time. A couple of our major successes, we were able to build in long-term project sustainability within the community through the creation of our toolkit, which is currently being sort of disseminated through the city of Boise and being looked at on a variety of levels. And we were also able to continue the work of the local boards for the time being, and they're starting to work on some of the projects we recommended in the long term. And so we designed this toolkit for neighborhood food evaluation kind of based on this spectrum you see at the bottom here, moving individuals from severely food insecure to individuals who are able to not only access healthy, affordable food, but are able to cook meals that are healthy for their family and understand things like budgeting and just food preparation in general. So it's a step-by-step process that we think is a pretty good approach to looking at neighborhoods specifically. And with that, that's our local level project-specific example. And we'd love to answer any questions, both on or offline, if you have any questions about our project or the Plan4Health Coalition in general.
Super. Thanks, Aaron. That was a powerhouse presentation. And thank you, Arthi, as well, for your presentation. I did see a really interesting question come through from Michael for Arthi, talking about how does the information, your presentation, impact economic development, the grabbing of the data, the use of the data, and with a question about, do potential companies use this type of data when selecting a site to locate or relocate a business? And I think related to that, maybe just talking a little bit about some typical scenarios in which you'd start pulling the data that you described.
Sure. I think I can answer the first half of the question. I'm not sure if I can answer whether I know if companies are using this type of data. That I'm not sure about. But how you can use it for economic development, sure. And I think the Atlanta Regional Commission is already doing that. And they are the ones publishing this data, and the MPOs, right? So they're already using this for understanding where comprehensive planning needs to be done, or where the different land uses are developing, the density of land uses. They're already using this kind of data to inform all of that. And then you have the socioeconomics and the demographics that go with it. So absolutely, it's used for economic development, used for transportation planning, and all kinds of urban and regional planning purposes. So I know that it's being used. I'm not sure if companies are using this type of data. Yeah, I don't know if they are.
And then other kinds of scenarios where you think you would go and to pull a data set?
So I can definitely speak to the health strategies that one might look at for this area. For example, I found that, so I couldn't show you this slide in terms of, because the images didn't come through, but I did find statistical associations between lung cancer and agricultural land uses in the periphery. And the data was also given to me by mortality by place of residence. So I know that these are agriculture communities where people are working in agriculture and living in those same areas, right? So, thinking about how we can have intervention strategies and how we can have occupation-based communities and how we can use land use data as a signal, not as a causative mechanism, but just as a signal that we may need some special attention, like in terms of lung cancer screening or better farming practices or things like that. And again, this was a cross-sectional study. So I can't make, again, any causal inferences to say that the agriculture causes lung cancer. That's not what I'm saying here. I'm just saying that if you see these associations, it helps you dig deeper because this is a high-level view, right, that helps you zoom in and say, okay, these are the predominant problems, and so this is how I'm going to address them in spatially different ways. For example, when I look at heart disease and diabetes, I saw less land use effects, and I saw more neighborhood deprivation effects, right? So if you were going to intervene in deprived communities, what would you change or what would you make better so that you see less heart disease and diabetes? Right, and it's really a good, interesting conversation to think about what neighborhood deprivation really measures, you know, and how different is it from land use, right? So you can easily see neighborhood deprivation as a proxy for finer level land uses, which can't be easily represented in regional level land use, land use data. Right? So there are really two sides of the same coin. So these were some of the scenarios where I think you can use this kind of data and this kind of analysis.
Great. Thank you, Arthi, and thank you, Erin Mondada. We have reached 4 o'clock, and I didn't see any other questions come through. I really appreciate everyone's time and patience at the beginning of our webinar as we were having a slow time getting started. And I hope that you'll all continue to join us with other future sessions that we have planned. For those of folks who are joining with connections to public health, you do have to fill out that SurveyMonkey that's listed on the screen there to get your continuing ed credit for CHES. And of course, if you're a APA member, AICP, you can simply go into the system and use the event number listed there to register for your credit. So again, thank you all for joining us, and thank you to our presenters, and I hope everyone has a wonderful rest of the day.